a 77 years old man comes to the emergency department because of a 2-month history of severe muscle cramps and back pain. He said that he is homeless and has not
Homeless, okay.
and has not visited a physician in the past 20 years. He is 183 centimeters tall and weighs 62 kilograms. BMI is 18.5 kilogram per meter square. His blood pressure is 154 per 88 millimeter mercury, and physical examination shows pallor, multiple cutaneous excoriation, and decreased sensation over the lower extremities. Serum study shows like this. And the X-ray in the spine shows alternating sclerotic and radiolucent band in the lumbar and thoracic vertebral bodies. Which of the following is the most likely explanation for these findings?
Yeah. So first of all, what you think patient have problem? The diagnosis for this case.
He also have some muscle symptoms like cramp and back
Cramping.
pain.
Yeah.
And he has a little high blood pressure, right? High blood pressure.
Yeah, high blood pressure.
And also she have some cutaneous excoriation. I mean that's itching, right? Because he's itching, so
Multiple cutaneous excoriations mean like patient have the some problem with what we call because of the related to the increase the hyperpigmentation.
some abnormal sensation. So that's he will feel like
We call like you have the name for that chị cả. Let me check it. Okay.
And and that is the clinical symptoms. And about the laboratory, we see that he has a hypocalcemia, right? Hypocalcemia, and it's a high level of creatinine.
Yes.
Yep. Also the high level of phosphorus.
Yes. For the multiple cutaneous excoriation, it means like patient will look like itching and pruritus.
Yeah.
Because of increase in uremia. Urea. Yeah.
And in X-ray, we also see some sclerotic and radiolucent band in the lumbar and thoracic vertebra. Yeah.
So what make you think about what disease actually patient have?
I think that something make the calcium level decrease, and that's that caused all the symptoms. And also he also have some problem with his kidney because the creatinine level increase.
Yes, correct. So what exactly problem is the kidney? His kidney. Wrong, how you think?
About the kidney, I think he suffer from renal failure.
Renal failure.
Yeah.
Especially the end stage of renal disease or even like chronic renal failure. All right. So What happened next? When you see that?
That he has some problem with the kidney. So yeah, so is the activation of vitamin D is got some problem too because the vitamin D needs some factor in the kidney to be activated.
Yes.
But unfortunately, I forgot the name.
Similar degrees of the renal vitamin D activation.
Mhm. I'm sorry.
This is the degrees of renal vitamin D activation. That's what you want to say.
Yeah, a factor to help the vitamin D to activate it.
Yes, yes, correct. So,
Yeah, it, yeah. So see, he he has some skin symptoms like failure. Okay,
mhm,
signs. He has some signs in the skin like failure or multiple cutaneous discoloration. That's
mhm.
because of the decrease of vitamin D. I think.
Actually, for the multiple cutaneous excoriation because of uremia, increase the urine on the skin, the uremia. Hội chứng mạch tinh urea huyết. Yeah. So, what's the next? If the patient have that, so what's the problem? What the mechanism here? When
And he can absorb the calcium from the gastrointestinal tract.
mm-hmm,
So it causes a decrease of the calcium level.
mm-hmm.
Yeah, so because it causes a decrease with calcium level, it will stimulate the production of PTH in the parathyroid gland.
Mm-hmm.
Yeah, and I think that it called the secondary parathyroidism.
So until now, Vong, can you see a little bit different between like primary and secondary, or you still think it's really the same?
Yes, I think that is the difference is about the organ,
The organs, the place, effects.
yeah,
Especially when look at the past medical history. The second thing you look at the symptom the patient have. So is the patient have the hypercalcemia symptom or a patient have hypocalcemia symptom? So I want to ask you, what type of the symptom when a patient have the hypocalcemia in here? Hypocalcemia direct. It's not like affect the effect on that, or it's just direct. So when the patient have the hypocalcemia, what the patient can present, we can see here. When
So he also have some muscle cramping.
perfect, that's very important.
Yeah.
Symptom for hypocalcemia. Muscle cramping. In here, hypercalcemia, muscle weakness. Cramping is weakness, totally different. Okay, so here's a patient have the muscle cramping because of hypocalcemia.
Yeah. So the one more important thing that he have some abnormal sensation. That's the reason why he has some multiple cutaneous excoriation. I think because it's some abnormal sensation. So she feel itching and he feel itchy. So she kind of so cross on cross on the cross on the skin. So right.
Well, actually for this multiple cutaneous excoriation. This is because of because of increased urea, because of patient has CKD. Not really related to calcium hypocalcemia. So let's take a look at a little bit about the clinical symptom of the hypocalcemia. Like you said, patient can have the neurologic symptom, but that symptom will be like tetany. You know tetany?
Yep.
It's tiny like this. It's happen in the tetanus. It's really like the patient increase the neuromuscular excitability. So when the patient have the hypocalcemia, less neuromuscular excitability, but in the hypo it increase because of the is neuromuscular excitability. That's mean increase construction, yeah, or even like patient have paresthesia. When it's we call like paresthesia, like itching, tingling.
Yeah.
Even like sometimes we feel like have the needles sensation.
Yeah.
Needle sensation like a tingling. We call it paresthesia. You know that word?
Yeah.
I think one needs to write it down. Okay, it here. 1 sec. Yeah, we call like paresthesia. Stings, tingling, or needle sensation. And sometimes patients have the spasm, important, huh? Stiffness. Sometimes have my answer, and they have the test for that. The test like they do some the test like when you slap the patient. Sorry. actually they have this tap this, not slap, tap this, and the muscle very difficult to become normal. Like it's still construct, and it's need time to relax because the patient hypocalcemia. They have the name for some like the test like called or the trouser side. If you're looking for about the hypocalcemia symptom, you will know about this. As I remember, because of increased spasm and construction of the muscle, so it's a very slowly relaxation. And sometimes patients have a seizure. We call the neurological symptoms. And patient also affect to another place like cardiovascular disease, like maybe hypertension. It's not more typical, huh? But especially when you see patient hypocalcemia, you think about what happened with the calcium level like this. Is it direct or is it indirect? And then you look at past medical history, and you will see that. And explain again about what is a secondary hyperparathyroidism. When a patient have the decreased calcium level or even like increased phosphatate blood level, this will be reactive hyperplasia gland, thyroid gland, parathyroid gland, hyperplasia, increased development of parathyroid gland. That's the reason why increased secretion, BTH. So this is secondary. It's not like first primary. They have so what caused the cause? We know about the mechanism, right? So what caused the cause? So who knows? We will have to hear like CKD. So do you know about another cause? Okay, so what have the cause?
It's mostly popular is the kidney disease, and also it also happen in some kind of condition like malnutrition, cholestasis. Yeah, because of cholestasis, our GI tract can absorb the fat soluble vitamin. Yeah. It to decrease the vitamin D.
Yes. So anything affect to the level of vitamin D synthesis.
Yeah.
Decrease. So it can affect to the calcium level.
Yeah.
And yeah, so it can be malabsorption, malnutrition. Yeah. Like when said, some kind of disease affect to the level of the vitamin D. degree level of vitamin D. It will be increased. Why is when it's a decreased vitamin D synthesis can affect to the calcium level because it decrease intestine calcium reabsorption because of the vitamin D can have the calcium reabsorption, increased reabsorption in the intestine, and it's the same pathway. So it's a decrease the renal calcium reabsorption, hypocalcemia, and increase the BTH secretion. That's it. So two of course can affect to the secondary hyperparathyroidism, disease, CKD, disease, decrease of vitamin D level. And just that, remember, don't need to remember a lot, just remember two main disease. Two main disease for primary hyperparathyroidism, two main disease for secondary hyperparathyroidism. That's enough. And understand about the symptoms, the lab test, so what you can change. So look at again about the physiology of the calcium metabolism in our body, and you can see how change in the lab test in here. Like so I will talk a little bit about how can we detect, or even like what we do when we see the patient have something changing the calcium level. So we see the calcium level increase, so we suspect patient have the hypercalcemia, right? Or even incidental finding. So you can order ionized calcium. It's free calcium or calculate calcium concern with the serum albumin is being combined together. What this? And you see the next confirm, just make sure to confirm this. And it still increase, so it means patient have hypercalcemia. So patient have the hypercalcemia. So next you will check the BTH level to see, so is it primary, is it secondary, is it another cause. So if the we call the hypercalcemia, this will increase the BTH, but the level of phosphate is decreased, so it means like patient have primary hyperparathyroidism. But if you see the BTH is maybe increased, but don't change in the phosphate, or maybe the BTH level is the normal, this can be checked about urine calcium. We call like calciuria, not calcemia, calciuria. So you check that, it's still increased. Maybe it's primary, but it's not decreased. It's a familial hypocalciuric hypercalcemia. Thus, you also have one of the cause about this, but we will not talk about today because just a lot of things to talk. Just remember two things: primary and secondary. That's first. And in here, we relate to something malignancy cause. And when you see the BTH level decrease, you check again what happened to the BTH. Is it happen that we have the like suppression or even like destroy the parathyroid gland? So you check to the BTXRB. So who know BTXRB? What is the name of that?
BTXRB is some kind of protein that has the factors do the kind of
we call like
it's just like PTH, but it's not PTH. Function like PTH. It's produced by some malignant tumor.
Yes, we call it BTX related protein. BTX related protein. Yes. So when we see that level, it may have some neoplasm or malignant symptom or malignant tumor or some kind of that. We call it paraneoplastic production. Paraneoplastic production. Meaning like when you see that, you have to raise your concern. Some malignant can happen. Normally you cannot see that. Like us, we don't have any malignant symptoms, so we cannot see that level. But when you see that, you see like have a neoplastic production. Because it's just secret from some tumor. Can be from the squamous cell carcinoma from the lungs, or maybe the head, the neck, or even the breast, ovarian, bladder. Lots of organs can secrete that if have the abnormal cells. So when you see that, it's mainly like, or even you check the calcidiol or calcitriol, This is also one count the products, the components secret from the BTH. So it's increased, it's malignant, you see. If the increase the calcitriol, it means like have the problem with the granulomatous disease. Granulomatous means like have the some granuloma or even the granular granuloma cell in our body is very. We see on the histology, you see the granulomatous condition. Because of the can be psychosis. Psychosis is a systemic symptom. It can happen in the lungs or even in another place. I will just talk a little bit about this. Or calcidion, also because of patient have lots of vitamin D intoxication, or even like increase of vitamin D metabolism. So it's also increase of BTH related protein. So in order consider another cause, like another cause can increase decrease BTH. Just that. Lots of things. Any question from this here? Okay, so actually, beside the primary or secondary, we still have tertiary. You know that? Tertiary hyperparathyroidism. Tertiary means like, when we call it tertiary?
Because it happened after the secondary.
Correct. And the result of the CKD. Tertiary is the reactive hypercalcemia, long-term elevation of the BTH because of the secondary hyperparathyroidism. Correct. Good job. Any question? It's a lot.
Yeah. So when we check for the increase of the BTH related protein, the level of BTH is still normal, right?
Again?
I mean that the BTH related protein increase in the neoplasm, but in this situation, the BTH level is still normal. I mean, it is two separate things, right?
So in this patient, this is still normal, or another case.
Another case, or in other case.
Another case is still normal. So what we think, right? What you want to ask about this, right?
I just kind of confused that whether the test for the PTH and the test for the PTH related protein.
They check the level of that.
Yeah.
So this protein produced by malignant cells. So what you want to ask, like?
I just want to make sure that the PTH related.
Okay, tell me, Vâng, when explain that. So
she asked, yes, she asked if the PTH related protein increased. So what happened with the PTH test is normal or is not abnormal?
Oh, it's not related. It's not related together. It's separate because the PTH secrete from the parathyroid hormone. But the PTH-related protein produced from the malignancy cell. That reason why I will tell you is if you see it's increase, it means have the problem. Malignant C cells secrete that only secrete from the malignancy cells. But they act the same function as a parathyroid hormone.
Yeah.
That's the reason why they call the parathyroid-related protein. But it's not a parathyroid hormone. This have the same function as a parathyroid hormone, but just produced when a patient has the malignancy.
Yeah. So we still have the test to order for the PTH related protein.
Sure. They have the test for that. Yeah, sure. Think about the malignant, we see that. And I see when I see that's the increase. Oh my God, it's a very bad news. You have to looking for where secrete that.
Yeah.
But normally it's not secreted. So where's secreted? Okay, so lab today. I have lots of table here. I think just train about the level of that. So I think you can take a look at this. And actually, I think it has a Mr. Leon here. He will explain more, or even what he wants to talk about this. Because for me, I will try to help you differentiate between primary and secondary, in even like some symptoms, or even the test, or even like the cause. Help you to differentiate between both them, because I think it's very important for and after that you understand well about the mechanism, about the physiology, about the metabolism. You can know when it's a change about the test. I mean the component of the test level of the component in there. So that's it. That's it for today. And any question? If you need any question for that, so I try to explain. No? Yeah. Okay, that's good.